Yeah, that's what we need to do. Nobody's on the air. Awesome.
I have just came out, so today's the third. This week, 2 days ago. It was the milestone was it was our milestone. Yeah, it's a split and design. Chiefly people can see transparency. Just extending touches here and give a touch. How do you, yeah, how do we use
Good finance. We have friends that don't do them.
See, so
Thank you very much for all of you for coming today. We'll start now, and as people come in, they'll be joining us. And this is one of the flagship courses in Health Innovators. This is the first one we started, and it's proven to be popular and supported by many people. And today there are about 34. Just cancel it.
Coming.
Thank you. 34 people are signed up for this software.
Sorry. That's okay.
So this course, this more of open forum brainstorming environment, is basically there's no set agenda. What happens during the meeting is I can't predict it when the class starts, but somehow magic happens. That discussion takes place. Everybody will have a chance time to present, talk about what they want to do, and get feedback. And at the end of it, you will see friends, people who can strangers, potentially get to know in about 3 hours about other people. And over a period of time, the best results are obtained by people who come on a regular basis to this meeting and other meetings. You know each other, and they become very close friends and do many other things. So this is a quiet, peaceful networking opportunity so that you can get to know the other person, everything about that individual. Okay. So as I said, this is one of the many courses we are offering. Health Innovators is a non-profit organization. Kalyan will talk about that. Kalyan is the founder of that organization, and we will talk about it in a few minutes about Health Innovators, what kind of things we do in that. But for this course, and for generally to keep set the context for all of you, these are some of the courses and events that we run on regular basis every week. So pretty much we have Monday through Saturday sessions running. All of that are free. That are open, basically. This is the whole idea, and our focus is entrepreneurs. The kind of people who, like me, when I started out, I had an idea. I wanted to build a business. Yeah, so my wife asked me, "What do you want to know?" I have no clue, but I want to build a business. Wonderful. And I then think about it, and then I get busy with my work. And something happens in my job. Is no longer sure, oh, I'm going to start a business. And then something goes well, then I go back. So back and forth. So I think all of us are going through that motion in some form. But sometimes it becomes more serious. This whole idea of place is for people like that to come and for a couple of hours, think about your entrepreneurial idea and talk about it. And see what other people say about it. They will give feedback this way or that way. Collect all, get that information. more you share, more you get to know. And in that context, I want to mention one thing. Whatever, you haven't signed any NDAs. Nobody has signed any NDA. But think as if you have signed a gentleman's NDA. If you hear somebody else doing something that's very interesting, don't try to go off and try to compete with them. Join with them. There's more fun working with people and making more money than trying to compete. Entrepreneurship is a collaboration game, not a competition game. So work with them, work together. You will find that it's a lot more fun, a lot more rewarding financially and others. That whatever we say here, passionate is presenting it is their idea and respect, and they will respect what you are saying. Okay, so it's a give and take kind of policy. Now, this one, first course, is basically what we are going to do here, and you will see how it evolves. I'll share with you how we do these things. On Mondays, and again, all of these are in the first four of them are in this room. Second, on Mondays, we are offering a class called Evidence-Based Entrepreneurship. It's a more class, and they'll be connected with a lecture format, also a workshop kind of arrangement. And that gets done on Mondays. And what we do here is a business plan, right? Now, not a traditional business plan that you can learn from Brandeis or MIT or something like that. It's a very smart, very up-to-date kind of a thing. It focuses on what entrepreneurs need to do for business plan, right, in the context. So we just basically write one page. We have a business plan canvas, I a coach, and we go through that. We have small teams working together. And so what happens is the idea that you may have here, if you take that, kind of come to that course, you can take that idea and start crystallizing it better, making it more organized. You get feedback from different kinds of people, and you can see what's your value proposition, what's your customer target, and you'll get better contours about what you want to do instead of a vague idea. Okay, and this takes you through the motions, and some people have really done that good job, and they really get much more clarity in their business model. Kalyan teaches a digital marketing class on Wednesdays that offers basically for Google Analytics and SEOs and all the metadata and all the wonderful things that you really need to know in the online marketing world today. And that happens on Wednesdays, 6 to 9, again in the same room. On Tuesdays, don't ask me why this is staggered, but that's because of the people who are involved at different times, basically. Jobs Forum, we are offering a forum for people who are looking for jobs, trying to network and connect and everything else. So if you look at all these directions as we go through, you will start hearing another aspect of entrepreneurship. What is the most important thing for entrepreneurship? Not the idea, not the money, all that's very important. The most important thing is your team. Who is with you? So that it will be always fun to have a good team, a good chemistry, a strong team, cohesive team, makes the product make it go much farther, and makes it a lot more easy. It's just like in a football, the teamwork is all about it. So if you go to a VC, the first thing maybe after the first, who are you, etc., they want to ask you, who is your team? So our idea is, in entrepreneurial setting, is to help you build a team first. The idea is you will see other people who have a similar chemistry. And they'll say, okay, wonderful, be on the team. As you work in the chemistry, ideas, everything else, and they get to know the person well, that's where the magic happens, as I said. Okay, so Jobs Forum is allowing other people who are non-entrepreneurs probably who want to come in looking for a job. But if you are there, you can also see who they are, and you can convince them to join, basically. Okay, so this is another way for us, and also people who just want traditional jobs to be able to come and meet others. So we are trying to bring in recruiters, companies, and other people to come in and so make the connections possible. Again, on a very quiet setting, without any big fuss. On Saturdays, on the 4th floor of this building, and it is a whole day out there, we do what's called HI hacks. So people who are coming through this process, they come and meet with us, and they work together to create either a minimum value proposition product or building teams, or me and Kalyan and others. There are a few other people who are actually service providers. There are people who do IoT, there are people who design, and people I do software. There are a lot of software developers. They all come in together so that we can work together and do the projects. And they will be taking their idea and actually working on it, so that if they see any challenges, we all help each other out, and we are actually encouraging them to take the project forward. The last two, WisdomNet and the design class for which you wrote gave the feedback now. These are the courses.
She's the lady who's going to teach the.
Design?
Yeah.
Oh, wonderful.
Yeah.
Okay. Wonderful. Welcome. So these courses are people who would come into us and say they want to offer a class. They have something to share with others. And we make rooms available like this during the time. And so if you want to try to teach something, let us know what you want to teach, and we will add to that and give you the resources, time, place, advertisement, etc. So you can start teaching the class. Okay. Now, WisdomNet is a class that is all about, but more, it's for entrepreneurs and others. It's a sort of I don't know how to explain this in a way that it is more meditation, calm kind of stuff. How do you have a lifestyle, perception of life, and how do you handle stress and all that other stuff? Something related to that. I am looking forward to seeing what he has to say myself.
Well, depression is a big problem for entrepreneurs, and he's addressing the mental health part.
So, design course is the lady is teaching, and this is something we're starting just now. The forum and these two are probably starting in about a week or two, and this will be starting soon. So, if you look at it, we have a whole series of courses, whole series of classes, and things like that. All of them are free, and you're free to come and join any one of them and participate in that. And more you participate, more you get to know, more you have benefit of the relationships that you can build. So having done that, let's see what we are going to do in this room here. Given that now you know what it is, I'm going to give to Kalyan so that he can introduce Health Innovators and indicate what Health Innovators is all about briefly, what we're doing. And then we are going to go around, each of us, to introduce about 2 to 3 minutes. And that is the purpose of this thing I gave you in front of you. You just filled out for yourself. It's like a cheat sheet. What I want you to cover in that time, the 2 to 3 minutes that you get, each of you, tell us about yourself. Introduce yourself, who you are, what you are doing now, what you want to do, what is your interest, and more importantly, what you're trying to get out of this. What would you like to see? Granted, you don't know anybody, so you tell what you want to get out of this meeting briefly. Okay, so there's not much discussion going to be at that point, but just basically introduce. Once we go through the whole cycle of all our introductions, then we will go through open up, and we will go through one-on-one or more organic discussions, and everybody will have a chance to talk about and share information, and also feel free to share your content, comments, and others to other people. Help others so that other people can help you. So that is the model that we are going to follow. So feel free to talk about during the second. I mean, after we have introduced ourselves, feel free to explain and ask any questions. It becomes a free discussion.
Thank you.
Okay. So I'll have to maybe a few minutes before Kalyan comes back. Yeah. And during the time, let me start off what Kalyan would start off. Basically, Health Innovators is a non-profit organization. It started about 5 years ago. And during the time, our initial model was to have monthly events. Every month, we had an event that allowed us to have a panel discussion. We brought some people in the healthcare community. And we went through that. And now it's continuing on the events 1 to 2 times a month on average. And there's a charge associated with that. There is great food and good locations. And we, in the process, have reached about 16 to 18,000 people in Boston area healthcare community. That covers everybody. Doctors, nurses, administrators, C-level executives in companies, students, researchers, you name it, all of them. And that is our strength. That is the kind of group we can leverage and bring on and help our startups. So if you have an idea that you want to test out, you know who to reach out in MGH, whatever it is, and we can immediately make connections and help you move forward. I'll let Kalyan talk about the rest.
All right. Thank you, Mohan. Hello, everyone. It's great to see you. My name is Cal. Hi, Ben. My name is Cal. I'm the founder of Health Innovators. I'm a physician and a pharmacist by training and education, and I worked in information technology for 12 years for corporate America here in America. And I wanted to combine both my skill sets, and that's why I started Health Innovators 5 years ago in this very building. Now we have a critical mass, as Mohan said, 15,000 plus people, local people. We have served 15,000 plus local people for the past 5 years. And this year we started our incubator program. We want to help people start businesses. We were entrepreneurs before. Boy, it was so hard for us to build something, take it to the product, take it to the market. It was so hard. So we figured that we need to help other entrepreneurs who are going through this journey. So we're doing a lot of things. So primarily we teach people how to start a startup. Then we connect them to resources, technology resources, money, and initial customers, early customers. And we're hosting a slew of classes. This event today is great for market research. If you have an idea and if you want to throw it out there and get feedback from other people, because it's critical to get market research, because most of the time people fail because they don't do market research. 50% of the failure is attributed to market research. And Alba can talk more about that. She's a designer, and that's where she makes sure that people, people build what other people want. So with that being said, I wanted to talk to you about this one today. We are introducing a new product. It's our cloud platform. On this cloud platform, you can build healthcare apps. What we have in this part of the cloud platform is an electronic medical record system, patient portal, physician portal, interoperability engine, and so on. Pretty much you can connect to our Fire-based APIs, REST APIs, and you can access patient medical records. It may be on Epic, it may be on Cerner, Athena Health, eClinicalWork, we don't care. Our system can connect you and you can see that patient's medical record. The biggest pieces in the current app marketplace is that they're standalone applications which do not integrate with the medical records of the patients, and that's what we are trying to address with. So we want to help you build apps on this. And if you're interested, come talk to me and I'll connect you to the right resources. And Saturday, you bring your laptop on the 4th floor, and then we can hack and build the coolest apps. All right. So with that being said, I just wanted to quickly pass on to Alba. She's going to talk about. Okay. She's our feedback.
Okay.
Yeah.
Go ahead.
Oh, yeah, if you guys have to leave early, if you could please just fill out this very, very brief survey. It will take like less than 2 minutes. Basically, I'm a designer and user researcher, so I help organizations design their products with real feedback from real users, who are people who are going to be buying your product. So you want it to fulfill the needs of your users. So as Cal and Mohan have talked about, I'm planning on doing a couple of design and research workshops, and some of the topics that I'm thinking of are listed on the survey. So if you guys could kind of mark which things you would be interested in doing a workshop for, what are the kind of problems that you're facing right now for your product, and we'll come up with something really good that you will get a lot out of.
Fantastic. Thank you, Alba. All right, with that being said, let's go around the room and quickly introduce ourselves. So why don't we start with this gentleman? You want to introduce yourself quickly? You can't take more than 2 minutes, ladies and gentlemen, because the room is full. So we had to finish it before in 15 minutes or 20 minutes.
I'm Glenn Gutierrez from the Lake of Borica.
Hold on a
I'm
second.
your internist.
Tell me your name very clearly.
Glenn Gutierrez.
Glenn.
G-L-E-N?
Yes.
G-L-E-N-N.
Yes.
G-U-T-I-E-R-R-E-Z.
Yes,
that's right.
I'm an internist. I work full time there. And I saw the meetup, and I was just interested in the topic, and I wanted to learn more about it and find out what more I could see here.
Fantastic. So he's a physician from Leahy.
Wonderful.
Yeah. Yes. Yeah.
I'm John, and I'm a software development manager who's worked in healthcare IT software products for the last 10 years or so.
Thank you, Zach.
My first name is Chi, C-H-I.
CHI?
Yep.
Okay.
And I'm a physician at Boston Medical Center. So my specialty is I have finished training in internal medicine and endocrinology and currently working on obesity medicine. So my interest is in application of data science to healthcare. And actually, I'm also enrolled in a statistic program as well.
Fantastic.
Which hospital?
Oh, I'm in BMC.
Yeah.
Hi, I'm John. I'm a computer guy, computer engineer, and I've had some experience before in bioinformatics. Kind of looking for work right now, so I'm here to network and keep in touch with the healthcare field.
So you might be interested in the job story.
My name's Lem. I graduated BC a little over a year ago. And ever since then, I've been working at a healthcare-focused venture capital firm. So we invest in early and late-stage companies. And I'm currently working on deal flow right now for my firm. So especially within the diagnostic field and AI imaging space. And I'm here basically just to grab a lot of perspectives on either the doctor side, the provider, the payer, and just everything related to the market research that we go out to talk about here. So.
Thank you, Lem.
First name's Anish, NISH. Background, essentially investment management, financial service, a nonprofit, and consulting for the last 8-10 years. But my what I'm looking to get out of it, I think you summed up some of the focus areas here, from ideation to launch, and essentially kind of all the way until you start developing. I want to I've been part of in different capacity, from ideation to you're all the way up to designing strategy and beyond implementation as well. And I hand it off to the development team for coding, building applications. So for me, it's like kind of that. So I'm interested to talk to you after and trying to understand how you're looking to do that. And so that's where, and I think essentially learn about startups, where does it fit in, and about data. Because data is essentially used across multiple segments.
Thank you.
How do we leverage it?
Absolutely.
So that's the kind of space that I'm hoping to learn more from and share.
Oh, thank you, Anish.
Mayank, M-A-Y-A-N-K, M-A-Y, A-N-K.
Okay.
So I've worked in IT consulting from last 12 years. Last 8-some years I've been involved in project management side of things. Worked in different sides of healthcare during these years, from hospitals to insurance companies, product development, labs. Reason of coming here is a mix of what everyone said from Cal. I have that knowledge, but the idea has to come from the product. So that's like one reason. And other reasons are like so many different things are going in healthcare around the city as well as overall, coming from a closed circuit of healthcare. I remember back in 2007-8 of things where you see like this is healthcare, but now it's very interesting environment that we live in with healthcare, with IoTs and different developments, with analytics involved, science involved. So many different companies are putting their foot forward, and it's interesting, definitely. So to learn, the other main reason being here is when I work for a company, I just get involved in the things which we do on a day-to-day basis. So this is a good platform where we can know about what we can learn from each other. My background, I can definitely give suggestion in terms of product management, project management, especially different methodologies, and then background, I know HL7, I can maybe give some input on that side as well.
That's awesome. Thank you.
I am Mohan Venkatraman. I have been an entrepreneur for about 20-30 years now. I've made all the mistakes and I've all made the right things. I'm passionate about helping out and teaching and sharing the knowledge. My business, we build R&D. It's also an R&D company, and we are involved in all verticals pretty much: healthcare, energy, renewable energy, and otherwise, real estate, retail, applications for financial services. So we don't touch the board. in healthcare related, I do a lot with Health Innovators, working with managing all these things, basically. I would love to talk to more, all of you and get to know you guys and see how we can help you in Health Innovators and also.
Hi, my name is Yu Chen, and I graduated from Northeastern University. So right now I work in Young Health Innovator Forum. I'm associate. So I came here for looking for some startups and so exchange ideas with them, and we can give them help and looking for invite all of you guys to our forum in next 2 days.
Fantastic. Yeah.
So your forum on.
Let's continue on.
Yeah.
Introduction and we'll come back.
Yeah, we can talk.
We'll have a chance, lot more chance to talk about.
Yeah.
Okay. Let's get it.
So
Yeah. Hello, hi.
Any
My
extra
name
people?
is Tracy. I'm an outreach associate from US China Health Summit. And the reason why I came here is we are looking for the further collaboration opportunities with health innovators, including startups, incubators here in Boston. And we could provide you guys with quite a lot of the Chinese market resources and information.
Thank you.
Thank you.
Yeah.
Hello, I am Benjamin. I'm a recent grad from the University of Pittsburgh with a patent, and I'm trying to find that elusive first job in industry. So far, my experience is mostly lab and stuff like that. That's pretty much the short of it.
Well, thank you, Ben. There's a jobs event. You should come there.
I just heard about it.
Yeah.
You should come more often.
Hi everyone, I'm Vaishali. Vaishali.
Yeah.
Okay.
So I'm a recent graduate from Northeastern University, and I'm working as a full-time for a surgical manufacturing company. So I'm working as a regulatory affairs specialist, and I'm here to network with the health innovators and develop my company's business ahead. That's what I'm doing.
Thank you, Vaishali.
I'm Sushila Bhambani. I am a leader in healthcare IT. I last served as director of portal services with Fresenius Medical Care, leading physician engagement portals and patient engagement portals.
Thank you.
Hey guys, I'm Dr. Gurleen. I did my specialization in family medicine. Now presently I'm pursuing my MBA, and moreover I'm interested more to get a more exposure in healthcare industry. And presently I'm working with the health innovators.
Thank you.
My name is Mac. I'm a software type, that's some of my other compatriots are. Mostly involved at the present with a small R&D organization in Bedford, which is developing a hearing protection product. And I'm sort of working with them right now, making the transition from sort of the high level market analysis and exploration down into the product design and particular user features. So yes, I'll leave some notes.
What's your name?
Alba.
Alba, A-L-B-A.
Go ahead, Alba. It's your turn.
Okay.
So everyone knows Alba, right? She's the designer. Go ahead.
Yes, so that's right. Peter Stevens. I work at the Johnson & Johnson Innovation Center across the street here. So I do investment in early stage medical devices, and again, primarily I've done last 27 years been doing stuff for medical device companies, but I'm just trying to make sure I educate myself and get much closer to the digital health piece, and obviously there'd be some things to fit into our products, and also just kind of maybe meet some people to help run stuff by as companies come our way, and try to understand how we can take them on.
Thank you, Peter.
Hi, I'm Alex Roman. I'm a transplant from Miami, Florida. I'm a recovering entrepreneur. And,
that's a nice title.
That's a good one. I'm being forced to take a job. My heart's taking me to a new concept, and in the area of digital health. And I'm trying to find, I think, Boston is a leap that nobody agrees with except myself. And I'm trying to find an intellectual home. And this just happens to be the first try. And hopefully it's what I'm looking for.
Welcome to the right place, Alex.
All right.
Hi, I'm Alicia, and I'm an attorney. I have my own law firm, Versant Legal. And prior to that, I was the general counsel and chief compliance officer of ICA Systems, a healthcare software company. And before that, the general counsel of Group Medical, another healthcare IT company. So I am excited about helping innovators grow their businesses and take their products to market.
Welcome.
Wonderful, welcome. You're just joined, so you have to introducing yourself.
So my name is Sarah Chang. I head up a nonprofit based in Boston, Massachusetts. We were founded in 1993. And we're dealing with an issue that I'm going to just quote Mother Teresa. She said, I've come to realize over the years that being unwanted is the worst disease that any human being can experience. So you can translate that as prejudice and biases, which is an invisible disease. And I think that it helps us understand the profound impact that prejudice and biases can have on people's wealth and well-being, people's health and well-being. So we take the Albert Einstein's approach to addressing it. He said you cannot solve a problem with the same consciousness that created it. You must stand on a higher ground. So the message we have to speak to people's consciousness says this: are you greater than the sun that shines on everyone? Black, brown, yellow, red, and white. The sun does not discriminate. We turn it into a song. The song was performed by children at the United Nations. So we have this campaign right now called Singing Equality Across America. We're sharing it with school districts across the nation. 35 school districts have signed up so far, and we're making it free, available to all school districts across the nation.
That's what you can.
Thank you.
We're doing a brief first introduction.
Thank you. Thank you.
Okay.
Good work.
So thanks, and I'm not cutting you off.
Sure.
Okay. Ben, I stopped you from somewhere when you asked the question, so there is a chance.
Well, what you had stopped me is I wasn't sure that when they said their event for young health innovators was this coming Saturday, I wasn't sure that was clear, so I was trying to say something about it to make it clear.
Wonderful. That gives you a segue to both of you. Want to introduce?
Yeah, it is this Saturday.
So you want to talk more about it? So
It's
that
in Harvard,
so
Harvard School of Public Health. Yeah, it's on Huntington Avenue. It's a forum that was like 12 of these startups. They can do their pitch, and the 4 finalists we chosen from that forum will go directly to Beijing, and we have a large summit in Beijing and also here in Boston in September, so they can try to face more Chinese investors and Chinese governmental resources and large hospitals in China if they want to do their clinical trials there.
Is this a competition?
Yeah, it's kind of competition. Yeah.
So what are you looking for from startups? At what level of? Most of them here are.
We're kind of a little late, so it's a pitch competition this Saturday, right? It's a pitch competition, so we're kind of a little late. The deadline is already over, so they already selected 12 startups to pitch.
Yeah.
And if someone wants to go and listen to the startups,
So listening to the pitch and networking.
yeah,
Pitches.
Yeah.
Okay.
yeah.
So most of the people here are early stage. I think. Okay. I don't think any of them might be at the stage of pitching, even if it were available. But networking is fine. But if somebody is interested in Chinese market, notwithstanding what you're doing in your event, I don't know if any of you guys have a product that you are trying to go into Chinese market.
Anything which works.
Cal and I are.
Anything which works here can be replicated over there.
I know you and I are, okay, because we have products we've been talking about Chinese market for a while.
Yeah, but we have Chinese investors that are really interested in the startup, the projects here in US.
I see.
Yeah, it's kind of just networking.
Yeah.
I see.
Yeah. So we met with
investors want to come.
Yeah, some people they're from Boston Angels and they have
Boston
local
Angel Club.
investors that will come. There are about 200 people.
Yeah.
Nice.
So we met Tyler, me and Mohan met Tyler, and we know Boston Angels Club, we know Canopy, we know all those guys you're working with. Yeah. So we'll be happy to promote your September event, which is your annual event. This Saturday we are hosting our hackathon, so it's going to compete with us, your event. Yeah.
How many of you have an idea that you really want to take to the market? Thinking, even if it is rudimentary, early stage, but an idea that you really want to do.
Am I supposed to put my hand up?
Okay.
Yeah.
Well, who else?
Alicia said yes.
You have one.
He has one.
That's okay. Ben, you, who else? Anybody else wants to talk about it? Okay. And you want to talk about your idea? Are you?
Haven't cooked it enough.
Okay. That's right. The idea is this: for those people who
I don't have a
haven't,
name for it.
for those people,
That's a start. That's a good start.
Okay. Even if you're not doing something else, so for those of you who have idea, here's a chance. 5-10 minutes, whatever. Explain what it is that you're doing and see what you're expecting from others. What are your pain points?
Mohan, a few people came late. You might want to explain that NDA stuff again and then start.
Okay. Basically, the idea is this. This is a forum for people to openly express their ideas, get feedback, talk about it, give feedback, etc. And in that spirit, even though we haven't signed, nobody has signed the NDA, assume that you all signed an NDA as a gentleman agreement. So if you find somebody else's idea appealing to you and you want to do that or get into that, don't try to go off and compete and try to build a competing product. Instead, join with them, collaborate with them. It's a lot more fun to have working with people making more money than going after and trying to do the whole thing. Competition has never worked in the entrepreneurial world. It's a collaborative game. So I would suggest people work with people. So you'll have two is better than one each, basically. So that's the kind of spirit. And we had this boost, at least when we talked about it. And in that, Ben, why don't you go ahead? You got about 5-10 minutes to explain what you want and what you're looking for.
All right. The idea
Close the door.
that I've been pondering is it's pretty simple, except for the manufacturing. Basically, it's a in-home personal blood test, and it can be anything from checking on your genetic disease to distributing STD workups to college students to whatever. Basically, the idea is nowadays they have blood tests. You go to the doctor, they tie a band around your arm, they stick a big needle in your arm, and they take several test tubes of blood. But the testing for that blood is just a coating on the outside of the test tube. Why do you need such a big test tube? Why can't you just use a much smaller prick and then have a bunch of different sort of capillaries so that the blood just goes like water getting sucked up into a very small tube, which I'm sure everyone here knows of capillary action like that. So let's use that. We'll do extremely small sample blood tests, and that'll make it more accessible to everybody and easier to do at home. And you could even ship it to Africa, and suddenly you can have this in rural places where you don't necessarily have the ability to refrigerate or store blood. You just clean, prick, drop, Band-Aid, done. The trouble is in the manufacturing. Most of the getting something that's that small, coated, and in the correct physical configuration to accept the blood, have it divide down the different avenues into the different tests, not get air bubbles in it in the wrong place. Mostly when you put it together, if you're making out of plastic, how do you do that so that you don't coat the wrong one in the wrong thing? And how do you do that so that when you put it together, which is essentially a molded plastic thing, even if you put the molded plastic together in pieces, the heat could denature the testing. So
the situation about healthcare. Healthcare is in still ancient history, no, ancient world. We are still operating at the speed of fax machines. The communication is going between hospitals and clinics and fax machines. We needed 20 kilograms of blood to do one simple test is the remnant of the past, where all the lab testing equipment requires that much. Microfluidics, things you can do the whole thing with single drop of blood that you can do, is not yet commonplace. So because of that, they're taking this much blood for a simple blood test. And when a patient is getting concerned about it, they said, don't worry, your body will make that much blood. I mean, when I have taken the simple calcium test and magnesium test and whatever it is, one for calcium, one for magnesium, they probably so much and I think that I won't have any blood left. I get concerned about it, but they said, don't worry about it, your body will make the blood. And you don't have a choice, they have got your needle on your hand, what are you going to argue about it? But no, resign to the field. So the technology hasn't improved in the testing side of it, which is a great opportunity for entrepreneurs and say, take that as a problem statement, say, what can we do? Can we change that model? Okay. I don't know, but denaturizing of the blood is an issue, particularly because you're looking for certain molecules there, and they don't have to be, meaning functional biological activity has to be present for some test to detect it. That's all.
I wasn't worried about denaturing the blood. I was worried that when you manufacture it, how do you get the test to adhere to the very small thing and then get that put together? Because every manufacturing method that I'm running through mentally involves at some point melting the plastic to another plastic tube, and even with the technology to do that with thin enough plastic tubes that they can handle capillary action, I'm not sure how the waste heat will affect the
You can develop materials which withstand high temperature or low temperature.
I'm not worried about the plastic withstanding. I'm worried about the testing material. It's basically an antibody. I don't want to manufacture the antibody. If we have antibodies that can handle that heat, then all I need is.
I don't know if it's a technical problem, but I think it's a good issue. Anybody has comments about it? Anybody has knowledge?
Yeah, I've seen people try to do that, where they were using some kind of suction and they were micro needles, and all I had to do was patch it on there, and it was just sucking, just like what you talked about. So I was just trying to look it up what the name of that product is. So you might want to. I'll share that information with you. And
I'd like to hear from doctors, physicians in this, and so what is your reaction when do you really need that much blood to do simple tests?
I'll speak first. Our current technology allows us to do finger stick sugars and INRs, which are basically anticoagulation measurements for warfarin. And a lot of those don't involve a lot of capillaries, but basically in terms of sophisticated paper that communicates somehow with the reading device to give us a number. And I don't know how those things work. I never studied it at all. I do know that's all I've seen that's been effective so far in terms of small amount of blood. You certainly could transfer that technology to other basic tests. I would find that the challenge would be what I would typically call the purple top tubes, the tubes that you have anticoagulants in. So I'm not sure how the technology would adapt to blood that needs to be anticoagulated in order to be run. And I'm not sure how that would work. Because you're talking about chemicals, but not talking about complete blood count requires whole red cells and whole platelets and all that, and having to deal with
complete blood counts.
Yeah, basic chemistries would be something that would be easier to do on this sort of a format, and I think it's feasible, certainly feasible.
But to your knowledge, what is the state of the affairs in the actual hospitals or clinics? They're still talking about large amount of blood draw or small?
I want to answer for that. It's like why it's not very large. It's some particular amount of a blood, almost 2 ml. We always take in a test tube. So it's all because sometimes while doing the test, because we never order, being the physicians, we never order just go for platelets, just go for RBCs. So it's a number of tests altogether. And when they carry out the test, there is a destruction of cells, right? And we cannot ask the patient again and again to give us the blood. For that, for a little bit, we take a little higher blood. I think so that it's like almost 2 ml of that blood is being taken out, and the different tests are being carried out because some of the tests are taken from the serum, some are from the cells. And by taking these small amount of, I don't think so they will be able to, because the technology he's talking about, there is a lady in US only, in early, I think in 2000 or something, Elizabeth Holmes. She tried to go for the similar technology, was just getting the test done, and from a pricking of the finger and doing all the tests. But it was proved to be fraud actually, right? So it is like that. The people are trying out this thing, but it is not successful up till now, all because due to all these things and all the mechanism that is being carried out in the blood. So because we need the cells, we need the serum, we need everything at a time for the different tests, right?
Other than the technology issues, there is no clinical reason that you need that amount of blood. You just want the results basically.
Well, actually, that's what I'm explaining you is when we extract the blood, the pathologist, when they get the blood from the capillaries or the arteries, sometimes during the squeezing, like there is a needle, through that they get it. When the blood squeezes into it, there is the destruction of RBCs or any type of cells that has been in there. So due to that, there are some of the cells being destroyed, and some of the cells are being lived. So we cannot ask the patient again and again to give the blood, right? So that's why we take a 2 ml of amount.
Let's say you have 2 ml of blood.
Yeah.
That is equal to maybe 100 drops or 1,000 drops.
Okay.
Each drop of blood has the same composition as any other drop in the blood, or is it different?
No, it's always like if you carry out this much amount, 1 ml. See, if we are doing the test from 1 ml amount, that is representing the whole one, right? Similarly, each of that has a similar constituency, and if there is a difference between that, it means there is some abnormalities there, right? So it's all like that. But taking that amount, yeah, I really appreciate your thing is like the people get irritated from all these things. But the problem is with this is like up till now, this problem has not been sorted, right? So that's the major thing.
I feel like we've drifted away from what I was trying to communicate, actually.
So he asked the question, why the so many...
Bring us back.
Bring us back.
Get back to what you want.
But the topic that seems to be developed is how do you do a complete blood workup given a single drop of blood? And that really wasn't my objective.
I see.
My objective, and also there was some talk about capillaries and getting the blood from the capillaries, and that's not really what I meant by capillary action. What I meant was something like I heard that in some of those test tubes, the test for the blood itself is attached to the outside of the tube. They put the blood in, it waits, they check it later, there's your result. I'm wondering...
Is that a visual?
I've never been around that vial long enough to know.
Okay.
I'm wondering if it is possible to do a small, select few specific tests for like particular diseases that you would do blood tests for by just having 1 drop of blood and having the entire system miniaturized to the point that the user experience is you put the drop of blood in the little well. It's taken from the well down little tubes simply by gravity or by the surface tension of the liquid, capillary action, not actual physical flesh capillaries, to the testing reservoirs. The testing reservoirs have in them the correct technology so that the blood binds to antibodies attached to the surface of the reservoirs, itsy bitsy reservoirs, and then that sends, it either changes a color somewhere else or it sends an electric signal because it's accepted the antibodies, it's found its thing, it's tested positive, and I don't want to, no, I do want it becomes almost as easy for testing for a panel of a small panel of diseases becomes almost as easy as a pregnancy test.
Or testing for blood sugar, right? So then now they do that, right, with that proper blood.
Right. And are testing for blood sugar. So I'm wondering, is there a way to manufacture a device using predominantly existing technologies that doesn't do anything different and doesn't try to do everything, but just tries to do a few easy things and make those things more accessible and cheaper to the population at large and possibly third world countries?
I want to project it. This is recording live.
Okay. Hi, Mom.
That's fine.
So I just wanted to share something with you. I just found a company called Seventh Sense Biosystem. So just check it on the phone, and they're talking about what you're talking about, and just make sure that your idea is different. So it says Seventh Sense Biosystems. That's the idea. That's the name of the company.
I think so. What you're saying is like you're not interested in all the tests. You just want like whatever test that could be done.
I'm not trying to do something comprehensive at this point. What I'm trying to do is start the technology moving. Just can we do 3? Not all of them, not the full workout, not separating plasma from red cells, from white cells, just 3 tests. I don't even know which ones yet because we're going to be picking the easiest 3.
But with the smallest sample, that's your goal.
Can you but from a single drop of blood and have it be an almost disposably easy testing so that people can do it at home?
Especially like when diseases like dengue and other diseases in the world, which is like, I don't know how much it takes to test them, but it will be good to test them.
I'm talking about the technologies we have. They live in big machines in big hospitals, and they work. And thank goodness that they work. But can we make it cheaper and more accessible? Because the easiest way to make it cheaper and more accessible that I can see is to bring it into people's homes. And that means smaller disposable testing kits, which we have for blood sugar and pregnancy and some other stuff. Can we do it with a disease rather than just a readout? Or is there some bridge?
What kind of help are you looking for, Ben?
I guess I need a physician and possibly some people who are familiar with many of these tests to help me figure out where the greatest need is and where the greatest need intersects with the easiest to manufacture. And then we'll pick, I suppose in the initial prototype, it should be 1, then 2, then 3. Just to see if we can make this sort of test possible, because that seems like the next actual step. And it's a step in the line of personalized medicine as well as being able to, I've said all this already, reach out to third world countries.
It's a good statement of what you want, good definition. I think at least some of the people here might be interested to contact. I would suggest that in order to pursue, after Monday meetings where we are talking about the business, making more consolidation, there you will be able to make connections, but you will be able to present probably next time or maybe a couple of weeks from now. If you go through the Monday meeting, you'll have a more cogent definition so that people can help you better.
Yeah.
Ben, a quick thing before that.
If anybody's
Just one quick question. You mentioned before, I think you said you had a patent.
Yes.
Is it relative to this idea?
No.
Okay.
No,
Thank you. That's fine. I just want to make sure.
He's a VC. He wants to make sure it's protected.
Yeah, no,
I wasn't
I'd
sure.
like to talk with you after, but it's not going to be about this.
If anybody else wants to help him or join with them, we will have the mailing list of all the people who are attending, and you can contact him.
So he's basically looking for physicians. So here are the two physicians, and I can help you as well. And you can talk to these gentlemen as well. And if you're interested to provide some advisory services to Ben and work with Ben, so please.
Likewise, we are talking about the design. There are people around here who can help you do the prototyping for the design. So that way you can test it out. Or you can
So someone who knows microfluidics as well.
I can get him connected maybe with the physician director of lab services at our hospital. I could do that.
Fantastic.
People that know the information.
That's awesome.
If you're talking about tests that you're talking about, he would be the contact
I'm not
person.
talking about making
Yeah.
something. The innovative part isn't the test.
Right.
The innovative part is going to be the miniaturization and the accessibility.
But you need to talk to people. He's going to connect you to the lab manager.
It's got to be someone that knows the
The
test.
thing
Yeah.
is, when you start with one idea, as you start gathering information, you will pivot a little bit here.
Yeah.
Okay, so I agree, we'll bring it back to what you're
It might,
thinking of the
it
core
might
area, but
completely morph by the time it actually becomes viable. I recognize.
Because there's a lot more limitations than just this. And so I think you're going to talk to the people that actually do the tests and run the machine and see how far you got to go back and redo this thought. That's all.
I think you're right, it's
Yeah.
about the process.
Yeah.
I think trying to visualize something what the end goal is, which is good, but then that also requires understanding how you get from A to B.
Right.
And that requires understanding of the process of how things are done currently.
Yes.
To be able to, we talk about automation.
Yes.
And that's industry agnostic. That's just, every industry segment has that.
Yes.
So it's about trying to understand that process. And I think that's
Absolutely.
where hopefully.
Absolutely.
I like that word process because that's closer to what I'm trying to develop. It's not a new thing, it's a new process.
I see.
It makes it more accessible.
That's good.
And I think you also need to figure out what type of user you want to target. You're talking about home testing, but certain users would test for certain things. Like if we are in the United States, what would I test at home as a woman? Would probably be a pregnancy test, maybe STDs, maybe, I don't know, diabetes if I'm worried about, I know I have that in my health record. But that's a very different need though from someone who might be in Africa where there's like a high HIV incidence, or you're trying to measure dengue or something like that. So, and each of those tests will then determine like what experts you want to talk to about how that testing process works and what are the requirements at the molecular level, at the technology level. So I would.
That's going to be a somewhat more complicated question, I acknowledge.
Right, so I think it's like you just have to figure out where do you want to start first?
Yeah, I think
what type of user do you want to
start somewhere simpler.
Yeah.
So they can prove out. You can do a POC.
I'm not trying to make it do everything. I'm trying to make it do something.
But do a proof of concept, exactly what Alba is talking about.
Yeah.
Identify a segment,
Right.
a geography,
Yeah.
a customer base.
Yeah.
That's easy to
Right?
that's
And then
that's
define,
easy to develop.
do these three, then define a process with the help of experts.
I think I need to talk to the experts first because they're going to help me to figure out which test and which user base is easiest to access.
And I understand, even before you go there, for example, diabetes, blood sugar, and other related stuff are very common. Pregnancy test is very common, right? Most people do it. But other than that, like when was the last time you went for a blood draw? Like how often do you do in a year? Maybe once or twice or three times. So you have to look at, even if you develop some test and you're doing for a home-based market, what's your volume of that? If you're only 100,000
of scale.
And what are you gonna?
Then it's not worth it.
Which implies that maybe some of those the African bases might have been better.
Again, we're jumping ahead to solutioning.
Right.
Go back to the experts first, like you already
Figure out
said.
if
That's
there's
what
an
I would suggest.
avenue.
I think that the most beautiful technology fails in the hands of the patient, application at home. If you're looking at the home setting, I would really study the experience of what you're trying to achieve and how that translates into product design. Thankfully, in my experience, I've seen patients ditch beautiful things because it just doesn't match the experience that it was conceived on an environment like this, enamored of the technology and the solution, but really forgetting about the problem.
Well,
And also,
and specifically for diagnostics, you need to figure out what's the patient going to do with that information. I remember we were very excited at J&J back in 1994. We had this, home AIDS test, and then we put all these people, and then we realized that it didn't work. People didn't want to get the news because there wasn't good solutions at the time. So you ended up not wanting to be done at home because the people want to get the information unless it's,
Unless there's also
so what are you
anything
going
you
to
can
do
do
with
about
the
it.
information? What am I going to do? It doesn't matter. Yeah, I've got a rare disease. So I better
You're
go to a
right.
doctor,
You're
right?
right.
So
That's what happens after is a very important
Something
question. Right.
But with today's technology, with this cloud-based technology, we can push patient-generated data into the electronic medical record system. That's what it is.
That's right. I mean, it's
Yeah.
just the situation, the environment is changing.
Yeah.
Technology, the whole the way we interconnect is all changing. So what may not be meaningful last year, maybe more now.
Yeah.
So you can
Suddenly,
never.
rather than needing to go for a big stressful blood draw, you can almost hit yourself with an EpiPen and plug the EpiPen into the computer. Okay, not Epi, but
That's the biggest problem. I'm sorry. That's the biggest problem right now, right? Physicians have the clinical data, and that is episodic data. You only see the patient when you see them, but after they leave, you have no clue what happens to them. And that is the data which physicians want. Is patient-generated data, IoT data, genetic data. So when you combine that with clinical data, then you can get more insights. And that's what you can do with the interoperable cloud solutions and things like that.
I don't want to
You're talking about
the problem, but do you guys have an opinion on PHRs rather than EMRs and EHRs, personal health records?
Yeah, I mean,
What
kind of opinion? Do you have an opinion, on adoption?
It's a terrible adoption because the experience is not good, and the engagement is not there from the physician.
Okay.
The patients can see all the lab results and things like that, but they want to have chat with the physician and things like that. It's still email. You send them something, so the experience is not there. They can see the raw data of the lab results, but it's not displayed in a consumable fashion for the patients.
Two problems happened in EHR market. It went into the market before it was really ready. So that it's very easy to develop a EHR system. Anybody who knows how to do the development of a software and a database will just stand still and say, hey, do it for me. Problem is, we went to it without standardization. So much so that we have several EHRs which don't talk to each other properly. We have HL7, we have some standardization of the data structure, but we do not have a good interoperability when those things went into the market. So now we have gotten a system where we have multiple people, everybody else is using their own systems. In Boston area, every hospital is using their own system and they don't talk to each other. Now this problem in other places doesn't exist. In telecom, where I have background in, we define a standard first and then build all the things. So when you take one telephone and connect it to another system, whether it's from Sprint or MCI or AT&T, it will work just fine because the standards came first and then the connectivity. Here in EHR, connectivity happened before the standards, basically. That's the problem. So now we are grappling with how to do the interconnectivity, how to do the transfer of information. And given the fact that healthcare is very reluctant to adopt new technology anyway, this is a bigger problem. You cannot change course easily.
And I think one thing messing with the EHRs and having watched healthcare for so long and been in IT for so long, I think one of the biggest issues we have is EHR true to enterprise applications, the times that they were built. There are slots that doctors have to go, medication tab and this tab and that tab. Whereas the old case history, if you actually look, when they were rounding with a patient, they would just write everything in a small place. The doctors are not given much more time to go and update all these things right there in front of the patient. They need to keep moving on. Our payer system doesn't support it. So we increase their workload so much that they have to prepare well before, and then they waste a lot of time doing notes. Whereas if we had actually simplified and taken that case system as is and done all the breakaway at the back end and figured out how to do it like we do with other systems, and actually thought of process and driven with process, we would be in a better place. We're doing it for supply chain, finance, telecom, everything we are doing.
That is the situation.
But not healthcare.
Healthcare, every other community is playing doctors,
right,
other than doctors.
Right.
So the database engineers are saying how the data UI should look like for doctors. Right. The insurance company is saying how much you should bill and what you should bill the ICD codes. The doctors are nowhere in this equation here.
You need to understand, doctors never asked for electronic health record systems. It was implemented to cut down errors.
Right.
There was a lot of errors. Nobody knows what's happening. To improve accountability, government said, all right, let's put some electronic health record systems and make sure physician enters everything so that if there's something wrong, we can catch them.
Which is great, but a physician is supposed to treat patients and he's not a computer person, right?
So it's
Yeah.
designed, it's
The
poorly
interface is
designed.
really bad.
Yeah.
The interface is
Yeah,
I see,
terrible.
No,
I see doctors just, after a 10-hour day job, just going back home, put 3 hours more, just
Medical notes.
just
Yeah.
rewriting notes.
See, having said that, all the negatives about it, these are all the great opportunities for entrepreneurs to set it right.
Sounds like it doesn't work, so.
So there are some workflow processes I'm hearing from people who are actually starting to drive the workflow process.
Well, the most exciting
Just-
news is Amazon entering the space.
I am not sure.
1492.
Microsoft did it, Google tried it. Solution is going to come from entrepreneurs. We have some good people who have done interoperability solutions.
Yeah.
Available today.
Yeah.
They don't have the marketing power of Amazon perhaps, but Microsoft had a huge power, but they didn't make it. They just closed the shop. Google tried that. They closed the shop. So
It's a lot of, a little bit of my background is interoperability and EHRs and fire and my finding was it's most of it goes to administrators and business strategies that do not see the value in sharing information and do not recognize the patient as an active part of the healing solution. It's just a passive part of it.
Mhm.
And I don't know if I don't want to cast blame, but physicians do not see. They could have a hypothetical value in knowing what happens outside the clinic, but it's not really part of the. They don't have the time.
the thing is that the technology is changing to the point that with IoT, the data gets entered directly from the patient to the EHR without doctors being there. With Alexa and other things, doctor data entry becomes easier as well.
Mhm.
So it takes time, but eventually it will streamline to a point that everybody's recognizing physicians are overextended here, and there are solutions that will make it easier. But it's take time.
Yes. We'll get to it, but why don't we get the opinions from the physicians here instead of us talking?
Since I was asking about it.
Just had a question because when you were talking about getting data in real time, has there been any talk about implantable devices?
There are people,
in terms of monitoring, in terms of either labs that you're talking about, or and have it in a real-time communication to a base system.
We have seen entrepreneurs come our
Good
way.
card.
who are proposing that kind of solutions. So I don't have anything that Kalyan probably knows.
What?
about something.
Pacemakers and all have real-time data. They're going on.
Yeah, they have
time,
it, but
right? So they are implantable devices where
but-
you're getting.
But is it something where you can just click on the computer, put in their number, and you can see it right off the
So
bat?
now I
Or do you have
know,
to be connected?
I've heard from Boston Scientific for some cardiology device. I don't know exactly which one, but there is something that they are working on that the physician can actually, so it goes through many hops, right? The device from the pacemaker has to go to a particular device which will do the translation, and then it would actually come onto a smartphone.
Right.
Where the physician can make the adjustment as opposed to having the
Right.
technician call.
I'm thinking of a Bluetooth adjustment and just
Right.
giving and giving
Is that the
ongoing
physician could do it?
Recording.
I think for their
Real-time.
back pain neuro.
Stimulator.
something, yeah.
So I can give you some opinions on this. That's awesome. Having devices that passively collect data, sure, especially good data.
Right.
The big challenge with stuff like that is is the data actually useful within some margin of error, right? And the other one is what do you do with it? Who does it belong to? What kind of privacy stipulations does it fall under? Whether it be HIPAA or whatever else. I mean, these are all challenges, and these are all very, very new technologies that were coming out. What with IoT, Bluetooth, low energy, 4G, etc. They all need to be figured out.
And a lot of noise. The biggest problem all IoT devices have is a lot of noise. So somebody has to, proper algorithms to get rid of that noise and actually, so we should look at Mac.
Right.
To get rid of that noise and actually get meaningful data that they can trend and can do things I think that is one of the challenges that a lot of people are working on.
I mean, it's one thing to put a device in something that just, you know, gives out crap data, right? But, you know, if you want to actually have, you know, something that where you can give, you know, meaningful input, you know, get some kind of advice as, you know, what to do with the patient, you want to be fairly certain that, you know, what's coming out of it is actually, you know, good and actionable, and it's consistently good and actionable, you know.
Right.
So,
yes, you're saying something. One second.
No, I wanted to just kind of clarify, sorry, Ben. Clarify, when you say noise, is it just about having a better structure at the start to collect data, which can then have a more refined, focused data sets, or is it?
No, I'm thinking more, you know, in the physical vision, right? So imagine like a heartbeat monitor, right? I mean, physically, how does it work? Okay, you probably have some accelerometers in there, some kind of motion-taking devices. Well, it's sort of like, you know, using a scale or using, you know, a measurement tool. You know, you don't get exactly, you know, X. You usually get X plus or minus, you know, some kind of deviation, right? How big is that deviation? Because, you know, if you're talking about, you know, something is, let's say temperature, right? Like if you want, you know, good physiological temperature, right? What does it fall under? Like 98 point something degrees. You know, you have to be accurate within, you know, a tenth of a degree Fahrenheit. That's very tight for conventional devices, right? And if you have a device that, say, consistently records data, but it's only accurate to a degree, rather than, you know, a tenth or, you know, ideally 100th of a degree, well, that matters a lot as to how useful it would be to the end user, clinician, whoever you give the data to, right?
So then isn't maybe, I'll try and reiterate, maybe rephrase it. What I'm saying is if the recording of data, that's what you're saying. It's so you're referring to the technology or the tool or the platform that records the data. So that's what I'm saying. Like the initial data recording, data collection, if that's done, if that's more precise, more focused, more targeted, then there is no deviation, or will there still be deviation?
I mean, naturally, there's going to be a little bit, but I think we're agreeing here. I absolutely agree.
Right.
But then again, this is an engineering problem, and sometimes you bump up against the limits of, you know, whatever parts or tools you're using, right? Like, okay, if you're using a temperature sensor, right? Like, okay, like it's really tough to get something that's, you know, a 100th of a degree accurate, especially when it's, you know, moving around, surrounded by fluid and God knows what else, right? So,
Ben, we cut you off.
that's my opinion.
No.
My question was actually going to be directed at the physicians. We're talking about all these different types of data we can generate via the cloud and getting it there, and everything from heart rates to blood workups. Would having this data actually get generated be useful to you? Would you at some point use it? In what form? Would you need it in like a graph, or would you need the numbers as it came in? Because I recognize physicians. I'm not a physician. Would it be useful to you?
If I knew someone had certain symptoms, and then I knew what their sugar and sodium and all their labs and blood remotely, and all their vitals, and I didn't have, and all I had was a visual, and that it gave me a lot of information to make a diagnosis from far away.
What's
so
a
having that
visual
data,
in this case?
well, that'd be some video, you know, whatever. But you know, you already have a device with you. That's going to be a device-based product. You should be able to see the person too. So that's all I'm thinking of in terms of.
Would you have time to quickly call the person and say, "Hi, your vitals and your numbers look a little funny. I want to take a. How are you doing? Please speak with me. Let me know."
The point of the device is to save time, right?
Yeah, right. Well, there would be some sort of a situation where there would be a alert. The patient had a certain set of numbers, there would be an alert. We'd have to call that one or find them or whatever. Yes. Yeah, it would be set up that way. But
So
in that ideal fantasy world we're talking about right now, yeah.
But this is important because that alert we can totally set up. So let's say potassium goes above X or below Y.
Right. Yeah.
But that's an important thing to keep in mind that I didn't previously know. I don't know about anyone else in this room. That's the what to do with the data part of it, which is
what Pete actually mentioned for you, right? That's exactly what Pete said.
Yes, that is what Pete was saying.
He said, if we see numbers when we did the test, which were outside the range, then what does the patient do? And so we're falling by that.
That's the very important answer to
that. You're looking for triggers, and then if it communicates directly, then I would have a trigger.
And how many triggers? So, you know.
It depends on how many tests you got out
so
there.
If you've got too many, will the doctor respond?
Don't you have trigger fatigue?
We have like a trigger for the individual. test and everything.
You have a trigger for the heart rate. You have a trigger for how you have certain triggers. You'd have to have a center to handle all these triggers, but that's a whole other thing.
So physicians like actionable insights. They hate a lot of data, but if we can do analytics and give them actionable insights, that's what they want. They want to take an action based on that data, but you don't tell them to, go through the data and figure that out.
No, you ask them what they want to know, when they want to know it. And
sure.
You get answers like that, and you pre-program it so that.
Yeah,
this isn't like some new data. I mean, this is something from television.
Yeah.
Pure genius. It has all the same. He's got all this stuff. It's all make believe, but it's basically, the whole dream there was having sort of
have you ever heard
implanted devices to read everything, and they had it remotely connected to their giant screens and whatever the TV world was, and it looked great. It looked ideal, but I don't live in that world.
Have you ever heard about the creation of the helicopter?
Yeah.
It originated as a comic book idea. Yeah. They figured this can't work, but it can hover in place and it can fly in any direction, and it sounded like a fantasy.
And our smartphone was from Star Trek.
So let's not write this off. I'll write this off just because
you can take picture of that.
Gave us a mock.
What's his card? You can take picture. Yeah, there's another physician here. Let's get. No, let's get his opinion. He's a physician.
Okay, so you were talking about the use application data in physicians' work and what kind of data the physician wants. Yes. I think one step further is I don't want any data, but I want the data to make decisions for physicians.
Ooh.
So let me give you
easy answers.
Let me give you an example. Let me give you an example. So there are so many repetitive
decision support. Yeah.
Yes, there are so many repetitive work and
in
physicians' daily work. For example, medication refill. Yes. So in many states, a medication refill is mandated that the physician has to do that. But actually, the decision making for medication refill, in 99% of the time, in the vast majority of the time, is a very simple decision making. It's much simpler than playing chess or self-driving car. So those things can be automated.
Yeah.
How come that something like a medication refill out by a robot, which will save a lot of time for physicians?
Tell us more about that problem.
Yes.
What exactly do you mean by physician refill, and what is a robot?
Refilling it
yeah.
Right. So I'm thinking if we can develop a robot to refill medications, so the doctors don't have to do that. Okay. Let me give you a little background. So what typically happens is when we see the patient in the clinic, and then we'll give the patient 1 month of supply of medication or 2 months of supply, and then after by the time medication is finished, then the pharmacy will send us a message, or the patient will call our office to ask for a refill. So they don't have to come to the clinic again to get another prescription. They can just go to the pharmacy to get a refill and collect the medications. And typically what we do is we'll go back to the electronic medical records. First of all, we see if the medication is still on the medication that he's requesting is still on the list of the medications that we're supposed to prescribe. Okay. And second thing is to see when was the last appointment, whether the last appointment was within 3 months or within 6 months or many years ago. If it was many years ago, we know we have not been following the patient, so we should not legally prescribe medication for the patient. But if the patient has a recent follow-up, and the patient is supposed to take the medication according to our medication list, then we should refill that. Then so this is quite a simple decision-making process.
Even if case like somebody only went for 2 months ago, they had an appointment and you had a refill, you had a filling for 2 months, and they asked for a refill. Do you really ask them to come again, or?
No, a lot of times we can just give them a refill. We don't have to have the patient come so soon. Yeah, we don't have to get them back so soon.
Somebody has to go in and check in the EMR if I know.
That's right, to check the EMR when was the last appointment and find out if the medication is on the list.
Yes.
But don't the nurses do that? Do the doctors do that? I thought
yes,
the nurses
so doctors do that now.
Wouldn't that be a simple matter of in the prescription, refill if needed, and just to tick on that? So you don't ask me if they come for refill, the pharmacist, I permit you to do it.
No, most of the data systems require
That
the
is
physician.
missing in the EMR. Basically, if the EMR was smart enough,
One
when they wrote,
checkbox?
yeah, it needs one checkbox, so we just need to call Epic
When
and
you're
say, guys,
authorizing
put
the
two checkboxes.
pharmacist. That's all it is.
Right, it's a simple decision making.
Yeah. Yeah.
There are some legal implications because
Right.
I've talked to doctors about this.
Yeah.
So there are some legal implications for this.
Oh,
And
yeah.
the legal
I don't-
implications is in 2 months, if the pharmacy just calls, right? If it's a new medication and somehow it is missed that the patient has had some adverse reaction or something, the doctor is liable in this instance.
No, but
the
thing-
patient can come
I
back.
agree with you, Sushma, but the point is here, the doctor is not trying to make an appointment. Doctor is going to get a call saying, I want refill. Okay, go ahead. That's all he's saying, right?
Yeah, so I know what
No, no, but
I know
yeah.
the situation you're mentioning. So what we typically do is if the patient call back, for example, started to take new medication, call back in a few days saying there was an adverse reaction he couldn't tolerate, we'll just delete that medication from the medication list. So next time when we see it, we know that the patient's not supposed to take that medication anymore.
No, that's fine.
Yeah.
But
You're
suppose you automatically just refill it. So the provider is obligated when there is a new medication, that when the patient asks for a refill the second time, the provider is obligated to actually check that the medication has been okay for the patient.
Right. So I think
Now,
that
maybe
can
you're
be
not
checked.
doing it,
Yeah.
and
No, no,
the
I'm doing
process
that.
is, but many doctors have to go back and do it.
Right, right.
They
So I
have
mean,
to
that
make sure
part-
that the
that part
medication
can
is
be-
okay, that they are then checking the
If
refill.
it is a new medication, the previous prescription medication is no longer available. The pharmacist will know that. They will say it's not available, so what do I do? Call the doctor, right?
Yeah. So I think the checking
does
part
not
can be
check.
done by machine. So I'm thinking if we can develop a robot to do the checking parts
You're
instead
not-
of letting physician to do that every time.
You're not actually talking about a completely automated process. You're talking about an automated assist to make the doctor's job faster and easier.
You
So
can
be-
understand it this way. Yeah.
So basically, he wants a decision support for prescription refill. That's all it
Is
is.
it rote? Yes, go for it. If
Yeah.
it's not,
Yeah.
put back to me.
That's it.
And so it will be medication dependent,
Yeah.
Patient state dependent,
Right.
comorbidity dependent. You know, there are a lot of.
So we can, in that algorithm, we can have all
You
the
can have
decision
all these
tree.
things,
Yeah, we can have the decision tree.
That is a good idea.
That's a great idea. We'd love to work with you on
The
that.
way
Good
the
idea.
process works
Yeah.
is that if you want to take that idea and move forward
Yeah.
as a champion,
Yeah.
we will support you.
Yes.
Okay? If you say that I'm a physician, I just do the problem and somebody else do it, I'll help you, then we will propose this or present this to the rest of the community as we doing our events. And if anybody shows interest in that, we'll connect with you. And then as a part of the team, all of us can work on it. So that's the way that this will evolve into the future. You will find somebody, if either you or somebody else will be interested in that, and it will move forward. If there's a need, there's always people who come. Anybody else interested in working on that? Yeah.
I don't like the liability cost on that. I'm not a fan.
Liability cost?
Yeah.
Explain, clarify.
My feeling is that if you're gonna sell me that product as a physician, you're gonna take on the liability. So that's sort of part of your cost in some way. You're gonna just sort of, it's their fault if something goes wrong. The company that does that take on the robot. The robot's company's fault.
The robot
Right.
will.
No, the robot will only approve those medications with the algorithms that are approved.
Right.
Yeah.
So
And if
it will be
errors are
liability
made
cleared
as a-
before, not
right.
after.
That's all.
It'll be cleared before.
Yeah.
And there'll be some that they
Yes.
can't do. They'll say the doctor has to look at this.
Right. But still errors can be made.
Just-
Errors will be made.
Yeah, will be made, yeah.
They will
So
be made.
that's my point.
Well, errors
So-
will be made. We can actually have some control over which errors will be made. We can false. Let's say the robot makes we can probably skew the robot to make more false positives than false negatives. So it bumps more things like, yes, you do need to look at this and this and this, and some of those you really did need to look at, and some of those you didn't really need to look at. But
If
there's
you get
some
too many
that-
of those, and we didn't get paid for the robot, did we?
Right.
You know what I mean? It's
my question is-
so there's you gotta balance on that.
I mean, that's good. Systems of
My question is, who else is interested here in this, to work on this project? Are you interested in that? As a part of Northeastern?
I'm
you
willing
have
to
been quiet.
brainstorm
That's why I'm
with
trying to ask you.
Yeah, I'm just concerned about the adverse event of the patient. Like, so what if, like, I'm a patient, I receive that medication. So what do I think? Like, next time if I go for a refill, since it's a prescription device, I would communicate that adverse event happened.
Okay.
So what would be like this? If it is for what investigation?
You're raising an excellent point. All this will have to be worked on.
Yeah.
As a good, this plus there
It
will
might
be
get
100
like
other issues that will come up as it
Yeah,
goes.
maybe patient tracking robot.
And actually, here, I'll put forward an idea for a minimum viable product, an MVP. You can literally just have a really simple application, right? It can run on top of Excel or MATLAB or pick your poison, any language of choice, any program of choice. Go through the database. You'll still be doing the check-in, but then the robot will validate it. And then you'll know pretty quickly, how well it works. It's just you have to mock up, right? Because what you're doing, because what you're asking for isn't hard. It's literally just like, okay, checking different things in some kind of database that exists against, something else.
So
I think that'd be just no need to do it up. Do it in like Excel. If you have to.
Yeah.
We'll follow through with you. Okay. If anybody interested, they can contact us and we'll
Write his email up there.
Are there any roadblocks in interfacing with Epic on this product?
There's going to be all kinds of roadblocks, and we're going to figure that out.
That's what I'm saying.
When you go through this cycle, we're going to have a lot of
Although if you want to get technical,
I don't know.
Epic has programming interfaces, APIs, right?
Yeah.
That are meant to talk to
Exactly.
apps and programs that people develop. So
Yeah.
it's designed for that purpose.
Exactly.
So it can do it. All right.
Exactly.
You'd hope that there wouldn't be robots, but then again, it's a big system that's not under our control.
Right.
I wouldn't worry about
Those robots will do whatever you guys do. We just replicate that thing.
It's not even really a robot in the strictest sense.
It's a program.
It's a program.
It's a software program.
Yes.
Yeah, I think you raised an interesting point about the risk of decision making by robots. So who will take responsibility for that? And actually, I thought about that is by making the decision process more automatic, that will save time for physicians. So that will make physicians work more efficient. So the physician can bill less for the same service to insurance company. So insurance company can potentially make money by encouraging automation. So they should be the party that's also responsible for the risk associated with automation.
I didn't quite follow that logic.
Right. So the logic is with automation, insurance company will be able to save money.
How?
Because we can see more patients with the same amount of time. So we can bill less for each patient service.
So the insurance is all
How do you get an insurance company to say, you can make money, accept more risk? They seem pretty risk averse.
I mean,
it's actually not necessarily more risk. If we use something, if we use robots, we have to test it and make sure it's not riskier than an actual physician. And if that's the case, then insurance company should be willing to take this risk because they're benefiting financially from a more efficient patient service.
I mean, there are clinical decision supports you use right now.
Right.
Yeah. Right. And it's a process of figuring that out and, finding those kinks and straightening that out. I mean, it's a process. I mean, I'm sure the clinical decision support you use today, I mean, it was buggy before and they kept on improvising it. And it's to a point where everyone is using it.
So here's my opinion on this. I mean, you're talking about one of the classic, uses for automation, right? I mean, automation was not originally, but one of the big, cases for automation is, okay, it's for repetitive tasks that require low creativity.
Yeah.
Stuff that wouldn't be served well by people because, things that people do inherently tend to involve a little bit of error.
Yeah.
And let's take the ideal case, right? You have this perfect system that'll go through your database and do exactly what you want to do. Well, your risk effectively becomes what? 0, right?
So the question is not necessarily who has the risk, but is the automated system actually higher risk than the doctor? Because for something as simple as this, it might actually be a lower risk option, and then somebody, all you need is someone to want to reduce the overall risk.
I mean, I'd look at a similar case study. Look at self-driving cars, because that's another. I wouldn't compare apples to apples, but that's another situation where you had something where people were originally doing the work, but then there's this move, right, to have it done totally by machines, and especially in the case of artificial intelligence, right? What happens when the machine makes a mistake? I'd look into that because they've thought about this a lot. A lot of smart firms with a lot of brain power.
Yeah.
So no need to reinvent the wheel.
Yeah.
Oh, you're saying
that's more on her.
For
And you got to remember
Check the liability.
It's risk is relative to an insurance company because insurance companies can take on more risk as long as they're generating more revenue. Because some insurance companies will only, insure, like in the case of automobiles, people that are good drivers, but some insurance companies will charge
or insure people that have bad driving records that charge more. So the way you want to look at risk in terms of insurance is whether or not the costs can be covered by the revenue that's been generated. So in the case of healthcare, you look at risk a little bit differently because you don't want to incur any sort of mistreatment towards a patient, because even a small mistreatment is
Big
huge.
liability.
Yes, it's a huge liability. Even if you're more productive and you're generating more revenue, the ultimate goal is to be able to provide higher quality healthcare more efficiently at a lower cost. But I mean, if you at the end of the day, what you want to do in terms of healthcare is you want to make sure that the number of patients being serviced are getting the same amount of healthcare or the same care with greater efficiency or better care with the same cost.
I absolutely agree. In fact, I think that actually almost be a bigger question in this situation. You know, does the tool that you're proposing, does it actually make things quicker and more efficient than things otherwise? Otherwise, who cares about risk? You know, no one's going to use it otherwise.
I want to give a chance to Sushila because I think she has an idea. I'd like to have a discussion for that, so she can leave. Go ahead, Sushila.
Thank you. I'm sorry. Didn't mean to interrupt. So I'm thinking of a nonprofit, and there are a few of us who are kind of working on it. So I'm very interested to hear your thoughts too. This is to encourage multi-generational bonding, bonding between elders and teenagers, almost like grandparents and grandchildren. So teenagers roughly between the ages of maybe 15, 16 to 19, and seniors. Encourage bonding over a period of time where they perform one-on-one, they perform activity together, an activity of choice, whatever interests them. Could be music, could be painting, could be, whatever they want. Could be arranging photographs if the teen is interested in doing that, recording family history, learning English, learning culture for migrant children who come. The thought behind this came as I looked after my parents and my in-laws. I've looked after them over an extended period of time and kind of watched my children benefit from there. And then I was watching other children. And I kind of found that these children, I mean, the elderly were very happy when they saw these children. They get a light on their face. My father-in-law had Alzheimer's, and still he would know. He could barely communicate, but he would know when a child came into the room, and there would be a very different attitude and very different behavioral performance, right? If I have to take him to the bathroom, get him to get his medication or whatever, he would comply. Otherwise, he'd be fighting every step of the way. And similarly, the children I found as they went into colleges or when they were put in difficult situations, the children were emotionally stronger. And I kind of noticed this with other children as well. The interaction seemed to work best when it was children and people of the grandparent age, not so much. So from what I've observed, there really seems to be a generation gap, and it's more age related. Not necessarily your parent or your grandparent, but if you have sufficient years in between, the children and the elders seem to bond. So with that in thought, I wanted to target juniors and seniors in high schools and freshmen and sophomore in colleges for community service hours, to work with people in nursing homes, assisted living, home care people. And as we take this further, just like you talked about liability issues, I'm sure there are many here, and I'm going to look at Alicia because I know she can help me. We want to take this to many, many places. So this can go from a simple model of just playing chess together to as complex a model of having either social work, psychology interns, or pre-med interns actually working and engaging in simple activities with dialysis patients, chemo patients, special needs patients, mental disability patients. So this could be taken much further. So as a simple concept, I want to try with the easier, simpler things and then slowly grow it to a place where it would help the vast majority. And I'm particularly interested in this mode. There are senior companion programs that I know where seniors help seniors. I know there are adopt a grandparent program where I know some kids from Somalia were adopted by grandparents here in Boston. It was a federally funded program. I kind of watched that. But I'm particularly interested in this because I want both sections of teens and the elders to benefit. So I want the ability and help to identify teens, because I've heard from many immigrant students who come where English is a second language, and when they come here, they're not speaking English, that many of them struggle to bond. They said we were in our own groups because we struggle to understand the culture and struggle to meet with other people. And they particularly said that if there was a program like this, they would have loved it because the peer pressure isn't there. When they're talking to elders, the elders are kinder on them, and they tend to benefit. So this is the idea that I've been kind of, setting off some market research on and trying to get more help and to grow the idea.
I think it's a great idea, personally, and I think it would definitely be a disease that Mother Teresa talked about, being unwanted.
Yes.
Because I think the elderly populations definitely experience that, and I've heard that in nursing homes, it's really sad.
Yes.
In nursing homes, many of the elderly people don't get a visit even from their relatives.
Yes.
It's really sad. So I think what you say, I think is a wonderful idea. I think the other part too, as I was listening to you, just the act of listening, in other words, the elderly, they have so many stories about their lives. All they really want is someone to listen. And then, as you said, the younger generation, they can learn so much from the elderly population. So I think the skill that we all need to cultivate, especially in this high-tech world, is listening. Because if you think about it, in the high-tech world, we're sending text messages to each other. But when are we really exercising our listening skills? The ability to really listen without assumptions and without biases. And I don't think we realize that listening is a very powerful way to heal. And I will just tell you one quick story. I do workshops around diversity and inclusion. And when I shared that Mother Teresa quote, a gentleman sitting right in front of me, happened to be African American, tears rolled down his eyes. So that quote somehow touched a deep part of his soul. And his tears, to me, I felt were healing tears. So I think the idea that you have is a wonderful idea. I think what you probably want to do is create a pilot.
Yes.
A pilot, and everybody wants data.
Yes.
So you create the pilot.
Yes.
And you get the feedback from the young people who are participating and from the elderly people. And that data is going to me would help you show the effectiveness of this. And then once you have a prototype, we all know this, once you have a prototype that's successful, then you just duplicate it.
So I think definitely liability issue was brought up. I've spoken to a couple of social workers. They are even willing to try this out. And I know some aspects have been tried out, I believe, with Hebrew Life, with Newbridge on Charles. And somebody in New Jersey, when I was talking, she said her daughter teaches art to some of the seniors. So there is a bonding exercise and she goes every week. And her daughter is a freshman in Rutgers University. And she goes every week and teaches art to 3 seniors. The biggest challenge I have particularly found, and I'd appreciate help, is how do we motivate teenagers? How do we motivate juniors, seniors, freshmen, and sophomore and colleges to participate for community service hours? How do we even tell them that,
I'm willing for
I
ideas.
would look a little bit at more at the economic incentives. And I think there's one startup out of New York, and there are several experiences in Europe where the aging is
Yes.
more of a stark problem. In the cost of living, you have the baby boomers generation that basically have homes that they are practically alone many times, and you have younger generations that cannot afford where to live. And there's a matchmaking company, I don't know if it's out of New York, probably Boston is one of their pilot sites that is doing this matchmaking. And I would, the case of high acuity, like the examples that you're using, I would, take it, even, recognize depression and loneliness as probably one of the killers, the silent killers, and the and common denominators of chronic diseases.
Yes.
At how this could, the economic incentives could be leveraged in order to, to ascend into the acuity curve. And there are things happening. I really don't have the reference, but it's worth.
So for children, one of the things I've kind of stayed away from is we have a culture of pocket money for mowing the lawns, pocket money for putting your laundry in to help your parents out. It has some advantages, but from an emotional caregiving side and actually building relationships, I don't think it works. I think somewhere we want the children to learn and understand that emotional bonding is intrinsic. It's beyond what you will get physically, whether be it cash, be it anything. Is that bonding is going to go a long way in making you stronger, making your life stronger. That is my message, and I'm trying to find.
I wouldn't underestimate the value in the coexistence in the human. And that might be, even though it might be the consequence of something else rather than the necessary condition for the whole model to work.
Yeah,
and keep in
that's
mind
a good idea.
Keep in mind too, like especially even when you're young, I've heard people say the opposite, but I argue that that's not true. But I'm going to argue that time is expensive. Time can be very expensive, and when you're spending time, with someone else, what is the opportunity cost versus doing that other thing? And I think, for people to consider this as a viable option, they're going to have to say, oh, you know what? They're going to have to make the rational decision, economically or otherwise, right? What does this option have that has advantages over any other things I could be doing with my time? And I think actually a really cool way to get your foot in the door, so to speak, would be to target college students. They're always looking. More kids are going to college than ever. Applications are getting tougher, more competitive. People are always looking for, volunteer opportunities, to kind of, make their applications stronger. I mean, that's a selfish reason, but at the same time, a lot of them do come out with, gratifying experiences in the end as a consequence of that. I'd say go for, especially, when you're in that target market of, basically teenagers, they're all looking to go to college nowadays. It's sort of like, a prerequisite.
So the volunteer or community service hours is what I can start off.
I think that'd be a really good way to
get a letter out of the deal.
Yeah,
if you
and we can figure how to get them a decent letter.
So I have,
if you phrase it.
I was going to say, can I add something real quick? Sure. Just working with nonprofits before, one of the most difficult things that we have to do in managing a nonprofit is being able to recruit volunteers and manage those volunteers. And this is true for every single nonprofit. So you're not the only exception. One of the benefits, one of the ways that you recruit people is by giving them an incentive to work with your particular nonprofit, right? And so there's like a scratch my back, I'll scratch your back, right? But outside of that, inherently, you have a wide spectrum of people, right? Okay, so you have one group of people that'll do it because there's some sort of benefit to them, but then there's another group of people whose behavior is a little bit different. Some people are just motivated by money and they spend their entire life making money, right? 24/7, like this is my time, like like a lawyer bills the clients, right? Every 15 minutes or however long.
60 hours.
Yeah, okay. And then you have people that donate their entire life to goodwill causes, right? People with the clergy or other nonprofits. And so there are people out there that would be willing to donate their time to you. It's just a matter of finding them. And so to me, it's much more of a marketing issue than a logistics issue. And again, this is a problem that every single nonprofit has. So what you need to do is be able to find people that are willing to donate their time. And once you do that, because there are going to be people out there, it's not going to be a large percentage of the population, but there's going to be more than enough people to where if you can find those people, you'll have more than enough volunteers. And then for the people that, as he was mentioning, like there's a scratch my back, I'll scratch your back, providing an incentive. And again, this is also going to be a marketing issue. How do you communicate your particular organization to the thousands of high schools all across America and find the students that want, because there's millions of nonprofits and there's millions of people, and these millions of people want to donate their time, and they cannot find a nonprofit that where they can be matched up with the right organization. We have Meetup, which helps people organize different activities, but it's not designed for nonprofits.
Well, maybe Sarah can help you there.
I agree with everything you said, because I've run my nonprofit now for 24 years. So he's right on the mark. Very, very difficult to find volunteers. However, there is this organization called volunteer.match, I think it's volunteer. And you can put out you're specific about what you're looking for in a volunteer. And the more precise you are about what you're looking for, then the folks that you attract will be, you've already kind of weeded them out by how you market the kind of volunteers that you want. And then you have to screen them out and talk to them. But he's completely right. It's very, very challenging to find volunteers. The other suggestion I was listening is colleges, there are a lot of sociology classes, and maybe you could present to any of the professors, say, would you like to consider this? To make it a requirement that the students interview somebody who's from another generation. Interview somebody from another generation and let them, whether you want to call it a final project or paper that they do. The other thing I was thinking, as everybody was speaking, videos are very powerful. So maybe if you videotaped a young person who was really touched by talking or listening to an elderly person, and then he or she, you videotape them. When I spoke to so-and-so, this is what I learned. It doesn't have to be more than 2 minutes, 1 minute, and show that. And so when the young people see it, they can be inspired by it, moved by it. It's like, wow, I'll sign up. If this is how it moves that person, I'll sign up to do that. You have to use the tools that we have, and videos are a very powerful tool. So not only videos, but words, using words. And it's about emotions. You got to push those buttons. And we all have elderly parents. So maybe it's going to push the guilt button. Like maybe I should go and visit my parents in the nursing home. And this person will say, not my grandmother, not my grandfather, but I went and I spoke to this person. And then, so those watching, it's like, how could, when was the last time I visited my grandmother, grandfather? So I think, video is a powerful way, and having somebody actually do it and then share what he or she experienced from the process. And it could be just 2 minutes. Okay. The video could be just 2 minutes long. And even producing a public service announcement, which is what we have. We've got a 30-second PSA. Right now it has over 4,000 views, over 82,000 reach. What do we have to do? We posted this 30-second PSA on other people's Facebook page. And so other people, you tie it into a point that's being made on the Facebook page. So if you get somebody to volunteer, produce a 30-second PSA, about what you want to do.
Okay.
Two suggestions.
Go ahead.
Two suggestions on are a slightly different direction than what has been discussed so far. And I may be asking Mr. VC because we seem to be some of the younger people in the room.
But that's okay.
One thing is that I remember being early college, high school student. A big piece of it was what I would have perceived the experience to be like. So, and part of that might even been the story content. So if it sounds like it's going to be fun, if it sounds like maybe there's going to be a war story, not just a droning back in my day, everything was better. I walked up the hill both ways to school and driving snow, and you don't know how good you have it. If that's how they think it's going to be, that's going not to attract very many people.
So we were thinking of some activities too, of choice, like sometimes people could share music together, could share photography together, could share art together.
Shared interest sounds like a great place to start. War stories
War stories. So war stories is your interest. I got that.
But then you can start coupling with the VA, because I know, well, maybe girls would be more interested in music and many other guys than besides me, but
that's okay. We'll find you a person, a football guy.
I'm not into sports. Anyway, the other thing that I was thinking, building off his comment of it can start in a monetary way and then move forward from there, is something closer to a roommate agreement or a renter's agreement, because there's a lot of college students and recent grads who are trying to move off of campus. Some of them may even have the ability to travel a little distance, and they're just looking for a nice place to sort of commute from that isn't super expensive. So maybe, I think that's what his comment on what was happening in other countries reminded me of. And I think that if you said, hey, very nice for not too much money housing, and your land person is a nice old person who you sort of interact with and have meals with every once in a while, that might be something that college students would be interested in, because it's not only a chance to sort of interact repeatedly in passing.
How many of you, everybody, would like to work with Sushila on this on an ongoing basis?
I mean, I can make myself available to talk with you.
I would love that, even to guide advice. I'm happy to do that.
Actually, jumping off Ishu's point, you can even, like, a lot of these elderly people, they need help, like, shopping, doing food shopping, picking up dry cleaning. Because I've seen elderly people, I'm amazed that they look so challenged to just do basic shopping. And I even asked one person, do you need a lift? I mean, so I think there's really some great opportunities to do the multi-generational, like you said.
Over a period of time. So I think for there to be really a benefit, it can't be I'm going to just shop for you today and then you're not going to see me or I'm not going to see you.
Building a relationship.
Yeah, so I think building that relationship is very important.
How about a year or two while the person finishes their degree in college?
Yeah, that's what I'm hoping, a year or two at least, and a regular, should it be 4 hours?
Well,
Dutch housing, I know, I saw that.
They have the big brother,
He showed
big
the
sister.
video,
Why
actually.
not call this, I don't know, I can't think of the name of it, with the title.
Grandma,
Yeah, or adopted grandparent, like adopted grandparent.
Yeah.
Adopted grandparent.
So they have that program, there is a federal program, adopt a grandparent.
Yeah.
It's being used for some of the children coming from Somalia to bring them to, to get assimilated into our culture here. So that is what I found, but nothing where they put the children for activities for a longer term. And that's what
I want to connect with few people who have not really participated a whole lot. Lam, you haven't talked a whole lot. As John, you've also been very quiet. Is there anything about any of you guys want to share with others? Like what you need or what others need. And so is for Alicia and Vaishali. So basically, you guys have been quiet.
Well, for your idea there, it's it's like more difficult in low population density areas where it's harder to find volunteers. Just some, I don't know where that leads.
So you bring up a transportation component. If we could transport the students to their homes and back.
Right.
I have been thinking about that too, because now there are people, all requires funding, and of course that will be my problem. Liability and funding will be my big problem, but that's something. So I'll note that down. I've been thinking about that myself, saying there's going to be a problem.
Might help you with that, because if they're already in college, that's half the liability sort of reduced.
College students? Probably, but if something goes wrong, it becomes a liability issue. That's what I'm looking at Alicia and saying.
I mean, you're right, if you're not dealing with minors anymore, then you're eliminating at least some liability associated with that, but it sounds like there are already programs, and so there should be models out there where you could have high school students work with or spend time with really people. And the question may be in what context. So it may not be that you can get into all of the different places that you had suggested. Like I'm thinking if someone is going to somebody's home, then there may be more liability issues associated with that than visiting in a nursing home where there are other people around.
I might be I'll help you if you work on anything in Billerica. So I've done home visits in Billerica, and I've been a medical director at a nursing home in Billerica, so I know that area pretty well.
Oh, perfect. I'm very happy to take your help. As Sarah said, I need to pilot. So if I find a few students and if you can help me, that would be
and I need to get a community service program set up for my Toastmasters. I got to work on that. So,
very nice.
So I might as well get something going.
That would be a big help. Thank you.
Anybody else has any projects that they want to talk about, their pet projects or thinking about? Maybe, maybe not.
When is the next meeting?
Every week. All these meetings are every week. So we pretty much every day of the week we are doing R&D.
Every Thursday?
We always so the best, most benefit for people are people who come periodically or repeatedly. For me personally, I need to see a person 2 or 3 times before I even get the name. I see the same person say, ask you what's your name, they'll be frustrated, but that's what I am. After 2 or 3 times, I know the name, face, everything else. So for you to make good friends, more frequent connections actually makes the relationship that much better. So I would encourage you to visit us and come by. For those of you who have not had a chance to talk about, if there's anything else, this is a great chance for you. You've already seen in the last 1 hour or so how people had the chance to share that information, get opinions and suggestions and whatever it is and connections they can make. And this is the benefit of being here. So it's your forum, your opportunity to talk and share and get information or volunteer. You've heard some people. There are lots of other people. Almost every meeting we see about 5 to 10 new people. And so if I know what you are interested in, and even if they're not here, we will be able to connect with the people who have been here before or who are working on it, we can connect you. So one of the things that you might want to do is to fill up this sheet of paper that will help us connect, find out what we want, whether it's a job or whether it is opportunity to collaborate with entrepreneurs in many ways. Few things I wanted to talk to you. I wanted to know Chief Fadlan. Basically, he's a VC and he's trying to. You want to talk about it? Basically, what you're doing?
Yeah, sure. So I'm not going to deviate much from my previous intro. So we're a healthcare-focused VC firm, and we invest in companies' valuations between $10 to $100 million. Some of them the bottom line is they need to be generating revenue. May not be cash flow even, but they're way past proof of concept and they're ready on the market. Right now, we're investing out of our fourth fund, and we still have about another 60 million left to invest within the next year. So as for me right now, coming to these kinds of workshops really helps with how I focus on my own diligence when it comes to sourcing other companies and also looking at the current companies within our pipeline right now. So I come here also to offer my insight as an investor, but more so as just a student, just to get the side of the payers and the providers, the other people I don't get to see that influence the numbers I see every single day.
What can we learn from you? I mean, we are at a conceptual stage, not even that probably, and you are at a $10 to $100 million. But there's we want to learn.
Absolutely.
That early stage gap.
Yeah. So
strategies.
That's my company's investment thesis, not my personal one. Being in college here, it's kind of rubbed off on me that lots of kids in my generation have all the ideas in the world, but don't have the connections to make that come to fruition. For example, there's this kid, he's my age, and yet he's dealing with an AI imaging company. So while I was off doing a junior year internship, he was forming his own company. So I was on the phone with him about a week ago, talking about his company right now. And as of right now, his pre-money valuation is around 5 million. My partners don't really care for that kind of stuff since they're, hitting their retirement age. But for me, being relatively young in both, the career sense and literal sense, these are things that do interest me. And even though my partners are looking at these 10 million things, they were looking at these small startups when they first started. So for me, being around all these young ideas while having an idea of what happens when they do become more developed and mature is essential to how I see myself developing within this industry.
The two things here. Tomorrow's big companies are today's little concept at this point. Some of them will be the ones to grow. And for those companies which are in the trajectory of growth, sometime they're going to need money. And at that point, trying to make relationship is meaningless. This is a chance to have interactions with people, and the insights that he can tell you can save you time, money, energy in the future. So that you have to say, what is important? How should I focus on it? What's really important for us? Then, because in entrepreneurship, you can be driven and distracted in different ways, and you can get an insight from people like him. And they are saying, okay, this is what I'm doing. What should I focus from an investment point of view if I need an investment in the future? For him, the opportunity is to see people start from at the seed level, so that it benefits him to know, okay, who are possibly the right people whom he probably can make introduction, either himself directly investing or connecting to other people. So there's a synergistic value for both, for him being here, and he has been here about 4 times at least. I mean, we have gotten to know him. And for us, for the rest of the community, here is the non-serious way of trying to look at and make a relationship with somebody whose focus is money or the investment. And that's what it was. Same thing, I think Alicia, the first time you come here, we'd like to have your insight of what legal stuff, what people should go here, what not, as we go on. So we'd like to welcome you to come to us more frequently, come meet with us more frequently.
Thank you. I will try to do that.
So this is your forum, guys, and there's really no specific end up to you. And it's open. Please do fill up this piece of paper, and also enjoy your coffee, cookies. Thank you very much.
That's a lot.
And your name?
I couldn't get around. I didn't get a chance to.
More ideas.
A friend of mine actually.
I wouldn't do it. I couldn't do it.
And
I don't.
This
It wouldn't
one's
save me a lot of time.